For this video, we will be focusing on non-Hodgkin's lymphoma, specifically our diffuse large B-cell lymphoma, or our DLBCL, and its most common treatment regimen. And as you might expect, based on the anti-cancer treatment regimens you came across back in Block 2, this treatment regimen is going to be composed of a combination of agents, including things like our conventional cytotoxic chemotherapies and different targeted therapies. But before we dive into our diffuse large B-cell lymphoma discussion, let's do a quick overview of general anti-cancer treatment options. So these treatment options are all going to target cell proliferation and survival, but via many different mechanisms. So a number of conventional chemotherapy classes will target cancer cell DNA by either inhibition of topoisomerase enzymes, which, if you remember from the infectious disease videos, this is the enzyme responsible for relaxing supercoiled DNA necessary for replication. These agents may also act as antimetabolites, interfering with nucleotide pools, or as being incorporated into the DNA structure, leading to disruption. And these agents can also act as alkylating or cross-linking agents in the DNA that lead to DNA damage, and all of which will impair DNA synthesis required for cancer cell proliferation and trigger apoptosis. Another primary target for our conventional cytotoxic chemotherapies are the microtubules, which are essential for mitotic spindle formation and cancer cell division and proliferation, as well as many other cellular functions. So these antimicrotubule agents either inhibit tubulin dimer assembly into the microtubules, like with our vinca alkaloids, or prevent microtubule disassembly, like with the taxanes. Both assembly and disassembly are essential processes necessary for normal microtubule function and therefore cancer cell survival and proliferation. So outside of these classes of agents, we have a number of targeted anti-cancer therapies that are chosen based upon cancer type and characteristics, like things like receptor upregulation, specific intracellular fusion proteins, and cell surface marker expression, just to name a few examples. And these targeted agents can include hormonal therapies, monoclonal antibodies, or small molecule inhibitors, just to name a couple. And then there are a number of miscellaneous agents that can be used as part of treatment regimens as well. And remember, it is very common for agents from different classes to be combined together to target the cancer cells via a number of different mechanisms. This will ideally mitigate therapeutic resistance, but also the agents are chosen to help limit the overlap of their highly toxic adverse drug reactions. And this toxicity we will come back to on the next slide. So for today's discussion of non-Hodgkin's lymphoma, specifically diffuse large B-cell lymphoma, we won't focus as much on the pathophysiology, which will be covered extensively in your IQ case discussion, but we will do just a really brief overview. So lymphoma is the malignancy of the lymphocytes in the lymphoid system and can originate from B cells, T cells, or natural killer cells during varying stages of maturation. And lymphomas can be classified as either Hodgkin's or non-Hodgkin's lymphoma, with non-Hodgkin's lymphoma being the most common. So diffuse large B-cell lymphoma is one of the diseases found under this heterogeneous umbrella of non-Hodgkin's lymphoma. And this is a B-cell lymphoma, resulting from the malignant proliferation of B cells during some point in their stages of maturation. So now that we know that this is a B-cell issue, let's move on and discuss the components of one of the most common treatment regimens for diffuse large B-cell lymphoma, being RCHOP, which stands for rituximab, so a monoclonal antibody, cyclophosphamide, which is an alkylating agent. The H in RCHOP stands for hydroxydonorubicin, which is also known as doxorubicin, which is an anthracycline, so a topoisomerase inhibitor. The O in RCHOP stands for Oncovin, which is the brand name for a vinca alkaloid known as vincristine. And lastly, the P stands for prednisone, which is going to be our miscellaneous agent we discussed today. And notice that every single agent in the RCHOP regimen hits a different cancer cell target to elicit its effects. So moving to our next slide. So now moving on to the specifics of each agent used in the R-CHOP regimen for diffuse large B-cell lymphoma. The first agent we will talk about is rituximab, which is a chimeric monoclonal antibody. And the central TU in the rituximab name actually stands for tumor and actually denotes this as a cancer-targeting monoclonal antibody. And this agent is for non-Hodgkin's lymphoma of B-cell origin, and our patient has diffuse large B-cell lymphoma, which is obviously a B-cell issue. So this agent is targeted at the B-cell population, specifically our CD20, and CD20 is an antigen found on pre-immature B cells as well as our malignant cell population. And when bound by rituximab, this induces apoptosis, clearing these malignant cells from the body. So as for important pharmacologic consideration, these are very similar to many of the other monoclonal antibodies we have discussed before, especially that risk of hypersensitivity reactions, requiring pre-medication, and monitoring during the infusion. And then there's obviously going to be those immunosuppressive risks with this agent. So for this agent specifically, there is a risk of significant cardiovascular events, as well as tumor lysis syndrome, with a high malignant cell burden because it is such an effective cytotoxic agent for clearing malignant B cells. Now we are going to move from our targeted agent to our more conventional agents, being cyclophosphamide, doxorubicin, and vincristine. And these are all designed to hit rapidly dividing cell populations, like our cancer cells, because rapidly dividing cells will be very dependent upon DNA synthesis and microtubule formation. But there are also several rapidly dividing cellular populations in our bodies that will also be heavily targeted by these conventional cytotoxic agents. So there are going to be a number of common adverse drug reactions across these conventional chemos. Their severity may vary a little bit between agents, but they're still going to be listed as common ADRs. And that will be bone marrow suppression, from targeting hematopoietic cell populations. There's also going to be diarrhea and chemotherapy-induced nausea and vomiting, as well as other GI side effects that are from targeting the GI epithelium. And then there's also going to be alopecia from hitting those hair follicles. There's also going to be a potential for mutagenesis, and this may lead to other malignancies later on in life. So moving forward, keep these in mind, and I will point out the additional notable agent-specific pharmacologic considerations moving forward. So now our next agent in the R-CHOP regimen we'll discuss is cyclophosphamide. And this agent is an alkylating nitrogen mustard, and it is activated to phosphoramide mustard, which can then alkylate and bind many different intracellular molecular structures, but its primary target is going to be the DNA, where it leads to the cross-linking of DNA strands, disrupting DNA replication, and this will lead again to this targeting of rapidly dividing cell populations, being our cancer cells, triggering apoptosis. So the big ADR and risk for this agent is going to be bladder toxicity. And this is because when cyclophosphamide is activated to that phosphoramide mustard, it generates acrolein, which is a highly toxic and reactive metabolite that affects the bladder epithelium, potentially causing hemorrhagic cystitis. So it is important to ensure appropriate hydration and frequent urination to limit this risk. And there actually is an agent called Mesna that can be given to detoxify the acrolein. So other notable adverse drug reactions for this agent include cardiotoxicity as well as gonadotoxicity. Up next is hydroxydonorubicin, known generally as doxorubicin. And this agent is an anthracycline. And how this agent works is it can intercalate into the DNA, which will interfere with DNA replication, but this is also going to interact with topoisomerase 2 enzymes, or topo2, inhibiting this enzyme's normal function and causing DNA breaks that are eventually going to trigger apoptosis in our cancer cells. The big adverse drug reaction for this particular agent is cardiotoxicity from the generation of free radicals that the cardiac tissue is unable to handle due to its insufficient catalase expression. Because of this cardiotoxicity, this agent is going to require a left ventricular ejection fraction determination prior to initiation and periodically to monitor therapy. And there are actually cumulative lifetime dose limits that are recommended to reduce the risk of heart failure. And this is a black box warning for this agent. Our next agent in the RCHOP regimen is Oncovin, which is the brand name for vincristine. And vincristine is a vinca alkaloid antimicrotubule agent. And this agent is going to bind to our tubulin dimers, which are the building blocks for microtubules, and this will prevent their polymerization into functional microtubules. This will prevent mitotic spindle formation, and the segregation of chromosomes, as well as impairing other cellular processes. So this is going to lead to cell cycle arrest and apoptosis in our malignant cells. So the big adverse drug reaction for this agent is neurotoxicity, specifically peripheral neuropathy that can be very severe, leading to significant tingling, pain, and hypersensitivity to cold, as well as other concerns like constipation, which is thought to be from autonomic neuropathy. So this is sort of the exception to those general GI adverse drug reactions we mentioned before that are common across all of the conventional cytotoxic chemotherapies. And another thing about this agent on this neurotoxicity theme, it cannot be given intrathecally with almost 100% mortality rate due to rapid demyelination. So there are a lot of administration warnings for this agent to ensure the proper route of administration is used. Now for our last agent in the RCHOP regimen, this is going to be prednisone, which remember is a corticosteroid that still goes through the same signaling cascade we discussed before, but now in our malignant cells. And this is going to lead to the repression of genes required for proliferation and survival, and the promotion of genes leading to apoptosis of cancer cells. So the other benefit to having this agent is that corticosteroids can help with chemotherapy-induced nausea and vomiting triggered by the other agents in this regimen. So for the sake of time, we will not revisit the pharmacologic considerations of corticosteroids, which have been covered in previous videos. So moving to our summary slide. I hope this video has provided a good introduction to the primary treatment regimen used for diffuse large B-cell lymphoma, being RCHOP. And we will continue to go over more and more anti-cancer treatment options for you to add to this list as we go through the cases in this block, so that when pooled with your knowledge from the malignancies covered in block 2, you will have a good grasp on the mechanism of actions and adverse drug reaction profiles of the different agents that can be combined to create these treatment regimens.